Hello, everyone, and welcome to our learning lecture on hydrocephalus in children. I'm Allison Serco, Regional Director of Community Outreach with Hackensack Meridian Health, and I'll be your moderator. We are very grateful to have Dr. Lawrence Daniels with us today. A little bit about our speaker. Dr. Daniels is the Medical Director of Pediatric Neurosurgery at K. Hovnanian's Children's Hospital at Jersey Shore University Medical Center. He is also the Director of Neurosurgery at New Neurons Neurosurgical Institute. Dr. Daniels is a fellowship-trained pediatric neurosurgeon who is comfortable with the entire scope of adult and pediatric neurosurgery. After graduating from UCLA's School of Medicine, Dr. Daniels was awarded the Washington Scholars Research Fellowship at the Maxine Duntz Neurosurgical Institute. During this research fellowship, he worked on the development of a dendritic cell vaccine for malignant brain tumors. Dr. Daniels also worked on research that aimed to selectively increase the permeability of blood-brain tumor barrier to increase the amount of chemotherapy that enters cancers that travel to the brain from other parts of the body. He completed his neurosurgical residency training at Albert Einstein College of Medicine and pediatric neurosurgical fellowship training at the Children's Hospital of Philadelphia. Dr. Daniels has research interest in neuro-oncology and craniofacial surgery and is currently conducting clinical and basic science studies in both areas. Thank you very much for being with us today, and I will turn it over to you, Dr. Daniels.
Thank you. Thank you. It's a pleasure. So today I want to talk to you guys about hydrocephalus. It's a common disease that afflicts pediatric patients, and it's something that neurosurgeons take care of a lot. And I think it'll be a great way to introduce the different facets of pediatric neurosurgery, from anatomy to clinical decision-making, diagnosis, and treatment. So we'll begin our discussions with a discussion of the pathophysiology and trying to get an understanding of hydrocephalus. We'll talk about the diagnosis, and then we'll go into how we diagnose hydrocephalus, and then we'll go into some of the treatments. And this is the first half of the talk. The second half, we'll talk about some of the innovations that are being developed in treatment and diagnosis and treatment of hydrocephalus. So what is hydrocephalus? So this is a definition taken straight off the internet, and it states that hydrocephalus is the accumulation of fluid in the brain. Hydrocephalus occurs because you have a mismatch between the production of CSF and the reabsorption of CSF. I have a question. Can you guys see my cursor if I move it?
Yes.
Okay, then I'll just use my cursor. All right. So hydrocephalus is a mismatch between the production or creation of CSF and the reabsorption of CSF. CSF is created typically in the substance of the brain, but as well in these specialized capillaries here called choroid plexus that occur on the floor of these areas here that are located inside the brain, these chambers called ventricles. And as soon as CSF is created by the choroid plexus and the ventricular lining, it's reabsorbed into the arachnoid granulations and the lymphatic drainage. So because of the majority of the CSF located in the brain is located in these chambers, if there's an accumulation of CSF, we can then get a buildup of fluid in these chambers. And what can happen is in a patient who's so young that their skull's not fixed, say for instance, less than a year old or less than 2.5 years of age before the sutures, which are the natural separations between the skull, fuse and the form becomes one piece of bone, the brain can expand and get larger. In the event that the child is older than that, then you can get a situation where the skull doesn't get larger, but because the volume increases, the pressure increases, and that pressure can cause damage to the brain. So in addition to the ventricular spaces, we also have hydrocephalus located in the subarachnoid spaces. These are the spaces that surround the brain, which are designated by this blue highlighting. And these subarachnoid spaces go all the way down to the lumbar spine. And there's actually more fluid in the subarachnoid space than there typically is in a ventricular system. And this picture I'm showing is because it shows some of the arachnoid granulations, which are one-way valves into the venous system, where as the pressure builds up, the CSF passively flows back into the venous system. and that's how a lot of CSF is reabsorbed. So what are the causes of hydrocephalus? So the most common cause of hydrocephalus in the pediatric population are intraventricular hemorrhages that occur in the neonatal population, increased risk in younger patients that are premature with not as well developed neuronal anatomy, specifically the ependymal layer, which is the layer in between the ventricles. There's a cell layer in between the ventricles and in between the cortical tissue. And those immature blood vessels have a tendency to bleed, and sometimes they can bleed inside the ventricle. And that bleeding in the ventricle can block the reabsorption of CSF and can lead to hydrocephalus. Myelomeningocele, a disorder that involves an abnormal development in the spine, where parts of the back are not developed appropriately, and the spine and the arachnoid space can be exposed to the external environment for the fetus, which is the amniotic fluid. We believe that that amniotic fluid is caustic to the central nervous system, and it can cause scarring that leads to a lack of reabsorption of that fluid, which can then lead to hydrocephalus. Tumors as well. Tumors can cause blockage of flow, and some tumors, depending on the type of tumor, like a choroid plexus tumor, can also increase the production of CSF, and that can contribute to this mismatch. And these are some other causes that are less common than the most common four at the top, which make up about 60%. So diagnosing hydrocephalus, how do we diagnose hydrocephalus? Diagnosing hydrocephalus typically starts from the signs and symptoms that the patients present with. So neonates, because their skull is not fixed and the accumulation of CSF leads to increased volume, some of the signs that we see on the physical exam could be increasing head circumference, splitting of sutures that are wider than they were previously in a previous visit or wider than what we'd expect. A tense fontanelle. Fontanelles are the opening in the skull where we can feel the intracranial content. And if the fontanelles are bulging or if they're under pressure and they're tight, it's an indication of pressure inside the brain. Once the fluid accumulates to the point to where it builds up pressure and it begins to disturb the function of the brain, we can get babies that present with apneic spells and bradycardia. And if it's really far along because the pressure's building up so much that it's really compromising the brain globally, it can lead to a global decrease in activity. Physical exam. So in physical exam, some of the things that we might measure or assess objectively on a patient would be the head circumference, a head circumference larger than 90th percentile, and specifically a head circumference that is growing in a manner that it outpaced the rate that would be expected to grow. And you don't see your natural curve, but you can see a more straight trajectory. And the disjunction of the sutures, which we talked about, that's displaying of the sutures. You can also see dilation of the scalp veins. Remember, some of these scalp veins are also being drained by veins from the sinuses in the brain by way of the skull, or sometimes by way of direct entry into the sinuses. And so if you get an increased pressure in the sinuses, which are located intracranially, it can then manifest to an increased pressure in some of the scalp veins, and you can see those veins become prominent and engorged. And we talked about the fontanelle, the tense fontanelle. Another sign that you can have is something called sunsetting sign, where the eyes are unable to elevate because of pressure on the brain and specifically on the superior colliculus, which can affect the part of the brain's ability to raise the eyes. So you'll get patients with the inability to raise their eyes and their eyelids drop low, and it looks like the sun is rising on the sunset or setting on the sunset. And then limb tone. So if you have patients who have chronic, albeit mild, disturbance of the general cortex, that chronic mild disturbance can lead to a plasticity and a rigidity in the limbs that can be detected with limb tone. Treatment of hydrocephalus. Treatment of hydrocephalus typically involves a diversion of the CSF that's accumulated into another space in the body where it can be reabsorbed. There's essentially two types of diversions. You have a diversion that's a shunting with a mechanism called either VP shunt or even sometimes a lumbar peritoneal shunt. VP stands for ventricle pleural shunt or ventricle peritoneal shunt, where a catheter is placed in the ventricles where CSF is collected, and in the case of someone with hydrocephalus, CSF is accumulating. And then it passes through this catheter through a shunt valve, which either just allows us to access the system so that we can test whether the system's working in the event that we're concerned that the shunt's malfunctioning after we put it in, or we can sample the CSF to make sure there's no infection. Sometimes, most of the time in a modern shunt, there's a system put in place that permits and allows us to regulate the flow somewhat, either regulate the rate of flow with a flow regulated system, or set a pressure threshold at which the pressure doesn't, the CSF doesn't flow until that pressure threshold is met. And then there's a distal catheter that connects to this valve system that then goes to another part of the body, either in the pleural space, in the lungs, in the peritoneal space. Sometimes we can put it in the atrium of the heart. Sometimes we can actually put it in the sinus where the CSF naturally drains, depending on specific conditions of the patients and whether they have issues in their abdomen or their pleural cavity. Now, there's another type of internal shunting that we can perform that doesn't involve a implant, where we stick a camera with a light source at the end of it called a neuroscope. We place that neuroscope through the brain, to the lateral ventricle, into the third ventricle, and then the floor of the third ventricle can be identified. If we can pierce the floor of the third ventricle, it can get access into this blue space here, which is the subarachnoid space in the basal cistern, and then circulate with the rest of the CSF in the subarachnoid space. And like we mentioned earlier, the subarachnoid space is actually larger than the ventricular space. And oftentimes we can get reabsorption in the subarachnoid space and internally shunt someone as a result of that. Now, so we talked about hydrocephalus. I'm going to give a brief talk, another couple of minutes about the future of hydrocephalus and some of the technologies that are being developed in neuroscience that are leading the way and hopefully going to create novel therapies for patients with hydrocephalus. So we're going to break this up into three categories. We're going to talk about training and diagnosis and treatment. So in the training of neurosurgeons, so there's a technology that's emerging that we all are probably familiar with. It's something called augmented reality, where you can take a digital interface that can show you a real-time picture of what's going on in your environment, and then it can add other digital elements to it in order to augment reality, in order to add additional information. And so there's technology being developed now to help residents and mid-levels be able to do complex neurosurgical procedures that are actually really, really common, but also really, really dangerous with really, really high risk and stake, such as placing an external ventricular drain. So in this picture here, you have a gentleman wearing goggles that allows him to see the outside environment like glasses. So there's a transparent glass, but on that transparent glass is a digital display. The digital display is reading this code, which is then displaying digital information. More than likely, it's displaying anatomical information on this patient, and then he's placing this tube that's about the sixth the diameter of a straw into the skull, hopefully placing it into the ventricles so that you can alleviate some of that pressure for that patient. So this is what he's seeing. This is the skull, and then these are the digital images that are placed on the surface of the skull because of this device here that the camera can read and place it on the skull. And so he's using these different tools to then get access to that area and place the drain. Now, there are technologies being developed for us to use this type of technology real time in the operating room and on patients for neuronavigation. We have a long way to go from a data processing perspective to make this technology accurate enough to use in neurosurgery, but we're at the beginning points of that process. And we're using technology like this for spine, albeit it's not augmented reality with the glasses, but it's using computer-assisted navigation. So now, diagnosis. So this is a publication that was presented in Head and Neck, and it talks about age-related volume changes in the brain and CSF. And this is important because oftentimes, in order to diagnose whether someone has hydrocephalus or not, we will get a CT scan. Now, you notice I didn't talk about a CT scan in this slide. And that's because you can derive a lot of clinical information before you get a CT scan to give you an indication whether someone's presenting with hydrocephalus for the first time. But if you have somebody who's treated with a shunt already and they're presenting with hydrocephalus, oftentimes, or if they're presenting with headaches or symptoms that might be consistent with hydrocephalus, but also might consistent with other things, oftentimes we'll use imaging studies and we'll look at the ventricular space and the size of the ventricles in the subarachnoid space to give us an indication whether there's an accumulation of fluid or not. But in a significant number of patients, their ventricles don't change, even though they may not be draining CSF and they may be under a lot of pressure. And as a result of that, there's a subset of patients where the sensitivity of a CT scan or an MRI are not such that we can rely upon them solely. There's technology being developed where we can let computers begin to calculate these CSF spaces. They begin looking at the CSF spaces in these patients, and they can then therefore identify subtle changes in these CSF spaces, as well as the cortical spaces, to give us an idea whether you have a patient that might be accumulating fluid, or whether you have a patient that might be experiencing pressure in certain areas. So matching all these data points, the artificial intelligence then segment these volume spaces in different patients, and then correlate these volume spaces based upon the patient's ages. What are the natural enlargement of the ventricular and subarachnoid spaces that occur with age? Because after puberty, everyone's brain shrinks. And as our brains shrink, our CSF spaces get larger in order to prevent our brain from swashing around in the skull. And that might put us at risk of something like a subarachnoid hemorrhage. But being able to calculate this and then develop what's normal allows a computer to be able to create a divergence between what's normal or not, and alert to us something that might be pathological in ways that the human eye can't detect. And we can't detect currently using radiographs. Now, another technology that's emerging and I believe really promising in the diagnosis of hydrocephalus are wearable devices. So we all use wearable devices. Wearable devices are common for us. We have rings and watches and these little other devices that can let us know how many calories we're burning, how many steps we're taking, our general health. My watch can tell me if I have AFib or not. My mom has the same watch. If she falls and goes into a rest, it can alert me and it can call 911 for her. So we have now companies that are developing wearable devices for patients with VP shunts to give us an indication whether a shunt's not functioning or not. The way this device works, which is called FlowSense, developed by a company called Rails, is there's this Band-Aid-like structure with computer mechanisms and circuitry inside of it that will then emit a heat signal proximal to the VP shunt as this is placed over the VP shunt like a Band-Aid. And then it will measure that signal and it will measure the temperature change and the fluid disto. And in that manner, it can indicate flow. And this is the device placed on a patient in an area where they have their VP shunt traveling. And right now, the device is good enough to tell us whether the shunt's on or off. But what they're trying to do is develop enough data to tell us whether a shunt's functioning optimally or not, and what's the risk that someone might go into failure in the near future. And then treatments. So we treat hydrocephalus with VP shunts predominantly, especially in the young patients. And part of the reason why that is because doing an ETV, an endoscopic third ventriculostomy in a really, really young patient, those patients have a tendency to heal and close off their ETVs very well because they're growing so much and their capacity to heal is so enormous. So in really young neonates, especially those with intraventricular hemorrhages, it's not the best way to treat them. We really don't treat those patients like that. So we have a lot of patients who still end up having shunts as the primary treatment of hydrocephalus. But what if you could try to treat someone differently? What if you can create a more physiological treatment for a shunt? There's a device being developed by endovascular surgeons called Ceravasc, where it's a endovascular shunting system. And this vein, typically one of the veins that drain the brain, that vein is accessed by way of the jugular vein, similar to what you would do if you were doing a central line, just in a slightly different trajectory. And once you access that jugular vein, you can bring that jugular vein up to the inferior petrosal vein, which is one of the main draining veins. But it also is a vein that it's located in the vicinity of the subarachnoid space. And so remember, the subarachnoid space that we referred to here, where a significant number of the drainage in CSF takes place, the light blue. The dark blue is the sinus. And inside the sinus, we have the arachnoid villi. And this is one of the natural pathways where as pressure builds up, CSF pushes its way through a one-way valve into the sinuses back into the venous system. Well, essentially, the endovascular surgeons are trying to make a small puncture and then place a valve system inside from the vein inside the subarachnoid space, which then will allow fluid CSF to flow into the venous system as the pressure builds up. And that's the end of the presentation. I hope you guys enjoyed it. I hope you guys learned a lot, and maybe we can do another one later.